Hello, everybody. All right. So, wow. After following Dr. Stieg and Julia, this is going to be pretty dry. I apologize. So, they say that the best people. She said that the best people don't do PowerPoint presentations. So here's a PowerPoint presentation for you. So what we're going to do right now is I'm going to kind of go over kind of like I would say a brief history, but it's not, and a non-brief history of dementia care planning. But before I do that, I kind of want to do things differently, and so I want to kind of get it a little bit more interactive because PowerPoints I know can be boring. So one of my first jobs was working in a movie theater. I absolutely love movies, always love movies. I remember the time when I first went to see a movie, it was only like $4.25. I know you guys probably, it was a little bit less for some of you, some a little bit more. Now it's what, $12? But my love of movies are there. I actually thought at one point I was gonna be in the movies. Obviously I'm here right now, so that didn't happen. My cousin though actually works in the movie industry, so I don't really like him right now. Let's see. So what I want to do is I want to connect my movie knowledge with sections of dementia care planning. So what I'm going to do is I'm going to give you either a synopsis or a story from a movie and then utilize that in dementia care planning. But this is where you guys come in. I'm going to actually put a picture of the movie on there. If you like the movie, please do this. Oh, hold on. Please clap. If you don't like the movie, you could boo, but then I'd feel very offended if you do that towards me. So let me give you an examples before we start. So see, I already got more claps than you, Dr. Steve. All right, so
that was a trick.
Yeah, sorry. What does a care plan look like? So a care plan can look like, for a dementia care plan, it could be a plethora of things. It could focus primarily on medication. It could focus primarily on non-medication interventions. It could include support services. It can include advanced care planning. It can include caregiver support services. It could be a mixture of all of them. But when we're talking about a care planning, we might want to look to see where it was before so I can give you where it is now and then where it's possibly going in the future. So, yeah. All right. So in Bill and Ted's Excellent Adventure, I tried to get something that's a little bit later, but okay. So in Bill and Ted's Excellent Adventure, Bill and Ted, in order not to fail their history class, they go back in time and pick up historical figures so they can present them at in an auditorium oral setting. I do not have half of these people that I'm going to discuss right now, so I apologize. So you're going to have to hear my dry voice. So what I have here is a timeline to give kind of a brief overview of the history of elder care. I'm not going to go over everything, but I will highlight some things. So Cicero, even Sina, and Maximinus all penned different books to show aging in the aging process and the loss of functions, what kind of daily activities you can do. Actually, Cicero actually wrote, and hold on, some of the things to do is remain active, know your limitations, be assertive, and he also said that sex is overrated. So that's a topic for another time. That was actually in there. It's true in my research. Okay, in 1823, the first home for the aged opens in the United States. That's in Philadelphia. It was called the Philadelphia Indigent Widows and Single Women Society. Van Oven pens On the Decline of Life. That's the first time that a physician linked that education to development of the aging process and how that can increase longevity. So the use of daily functions, the use of the aging process, the use of being assertive, remaining active. Sex is overrated, not really, but utilizing that to provide better ways to increase longevity for individuals. And the Visiting Nursing Society was formed by Lillian Ward in 1893 in New York City.
What does CE mean after the date?
CE, Common Era. So as opposed to BC and AD, I'm trying to be more politically correct rather than use the Christian ways of doing it. So BCE is before Common Era and CE is Common Era, sorry. Let's see, so next, Alois Alzheimer and the Alzheimer's disease consent, that was in 1906. The first patient that showed this memory impairment, known as Alzheimer's. The designation didn't come until 1910. Geriatrics was termed by Nasher in 1909. Medicare and Medicaid, no matter how much, whether you like it or not, which is very important, came about under Lyndon B. Johnson in 1965. In 1972, Geraldo Rivera, back when he was actually a real reporter, did an expose on the Willowbrook institution and exposed all of the atrocities that were happening within that institution with regards to how they treat their patients. I will talk about Dr. Jerome Stone actually a little bit later. The first assisted living facility opens in the United States in 1981 in Portland, Oregon. What this does is to kind of provide elders with more dignity and respect rather than what they had before, and I'll go into that. 94, Reagan was diagnosed with Alzheimer's disease, and as of today, 5.5 million people are diagnosed with this disease. All right, so Julie Bishop, she is the Minister for Foreign Affairs in Australia, and she is an advocate for Alzheimer's disease. So I like this quote because it promotes Alzheimer's awareness. So greater public recognition will also be critical in encouraging prevention and early intervention, and more generally in building public support to meet the challenges of dementia. So to get it out there is the best way to challenge dementia. Actually, Seth Rogen, does everybody know who Seth Rogen is? Knocked up, whatever. So he actually, a few years ago, actually went on Capitol Hill and talked to a committee to discuss and make aware Alzheimer's disease, which he then led to his campaign called Hilarity for Charity. Look for it online. It actually helps with regards to providing more awareness for the disease. Okay, good. So you're probably like, what does a horror movie about a shark have to do with anything about dementia? So let me tell you. So during the movie on the set, Steven Spielberg had a vision to actually have his shark be put into many scenes during the film to actually show the devastation of what the shark will do to these swimmers in Amityville. Unfortunately, that shark named Bruce malfunctioned midway through the actual filming. So he had to switch his plans, and the only time that you really saw the shark was near the end of the movie. He thought it was an atrocity, he thought it was a failure. It went on to make over $280 million domestically, which would rank it with inflation, number 6 all time. And it went on to receive critical acclaim, mainly because they did not see the shark throughout the whole movie. Why this is necessary in dementia is that even if things don't go to plan, there might be a success to the finish of the story. So these next few slides are the beginning of what we were doing with regards to dementia care plan. So early dementia plans of care. There really were none. People with cognitive impairments were put into almhouses, poorhouses, asylums, and institutions with very little dignity or respect attached to that. Very little privacy. They did not have really a plan of care, just kind of leave them there. So community-based service system was introduced. After the expose that Geraldo Rivera did, institutions started to close on a rapid basis. they wanted to have an alternative to nursing facilities. Nursing facilities at the time were not really accepting dementia patients because dementia patients did not, they did not have an understanding of how to work with them, so they did not really want to accept them. So this led to the long-term services campaign that the government advocated for. So here are some of the long-term services that we actually provide now. It's a process that has been going on for over 40 years. So when this first happened, not all of these were there. Okay, in 1974, the National Institute for Aging decided to do research for dementia to create an understanding of the interventions that could be used for support services. And they still are currently doing clinical trials in collaboration with the National Institute of Health with regards to dementia and Alzheimer's disease. They actually, I think last year had $400 million assigned to them for dementia research. Okay, so I'm gonna mess this up, so Rachel, I apologize. I know you're the head of the Alzheimer's Association, so I don't wanna go too much into it. In 1980, Dr. Jerome Stone founded the Alzheimer's Association. Basically, he was a public citizen. His wife developed Alzheimer's disease. He was flabbergasted that there wasn't a lot of resources out there for people who have Alzheimer's disease. So he decided to fund the Alzheimer's Association, and he is credited with changing the dynamic of services for Alzheimer's disease in the United States. Did I do that right? All right, all right, thank you. Okay.
Is this the old group or the new group?
The new group. Are you taking back your clap?
No, no.
Okay. In a remake of the 1960 film starring the Rat Pack, 11 experts at various tasks collaborate in an effort to rob 3 Las Vegas casinos simultaneously, including the Bellagio. So your mom would be quite upset about that. This section is the next section for dementia support and dementia care. This includes collaborations between a plethora of services and areas to become a more collaborative and comprehensive care system. So some of the support services that were evaluated during different times during the 80s, 90s, and somewhat today. So the Medicare Alzheimer's disease demonstration evaluation, and Medicare is very big on this, so they do a lot of the reimbursements with everything. So they do all of, they like to find out what's going on and what we could do to better accommodate those who have Alzheimer's. So again, the Medicare Alzheimer's disease demonstration evaluation, that was a evaluation of formal caregiving, formal professional caregiving, versus informal personal family caregiving, and adding of community services, whether that had an effect on limiting or reducing the caregiver burden. What happened when they actually had the results is that was inconclusive, although the community support resources were valued, and they are still there today. Alzheimer's disease demonstration grants to states. That's a lot, and these are all acronyms. So if you want to look them up, it's MADDE, ADD, GS. I'm done with letters. Okay, Alzheimer's disease demonstration grants to states. What that did was, hold on, and I had it. What that did was kind of collaborate primary care physicians with Alzheimer's Association chapters and aging service systems, mental health systems, and public health systems to get and create awareness of support services that are out there. Currently in New York State, that is currently New York Connects. So if you guys know New York Connects, that's basically where that came from. Resources for enhancing Alzheimer's caregiver health, or REACH. The first one, basically both of these, there's a REACH 1 and a REACH 2. The first one was designed to, well, both of them were designed to find out what is the best way to give caregiver support for those individuals who have Alzheimer's disease. So the first one, which happened in 1995, what that was is they decided, the National Institute of Aging decided to do a research to find out if an all-encompassing intervention, so a one-size-fits-all method, is good enough to help with caregiver support. They found out it wasn't. So they decided, okay, so if that's one of the things that's wrong, what we'll do is we will do this next one, REACH 2, where we'll have more of an individualized plan of care for caregiver burden and caregiver support. So that one is still going. That one was a little bit more successful. So there's that. Okay, so in 2006, and I told you it's dry, I apologize. Project Prevent. It was a study to determine the effectiveness of collaborative care for older adults with Alzheimer's disease in primary care. One of the things that they actually are doing right now is in Indiana. This is the Aging Brain Care Model. This is from geriatrician Chris Callahan. The thing that they're doing over in Indiana right now is developing a population-based medical record, sort of like what they're kind of doing here with the EMRs and putting everything together, and expanding a specialty memory care practice to care provided in patients' homes. So rather you going to them, they're coming to you. They're coming to you on the basis of community care managers, so what they're utilizing to make it more cost effective and more of a specialty care for the individual and the caregiver is to use volunteers who are specialized within Alzheimer's disease and dementia, and having them come to the home and utilizing their expertise with regards to services. So currently, the only thing that they're paying with regards to those workers is they're being supervised by a nurse practitioner. So the whole point of this is to create an interdisciplinary process to have a ultimate patient and caregiver satisfaction to create a better quality of life for them going forward and creating better access to care. However, one of the things is a lot of physicians are still saying that nothing's going to work. There's financial restraints, there's resource restraints, there's technical restraints with the information system, there's workforce restraints. So what do we do with regards to that? I like that. So in this movie, two neighbors, John and Max, are extremely stubborn and refuse to let a grudge that occurred during their childhood, they refuse to let it go. When the redhead named Ariel in the middle comes into the community, they both try to vie for her attention, but ultimately at the end, they become friends, albeit cynical towards each other, but friends nevertheless. So with regards to this, to change the dynamic of dementia, one of the things that we have to do is work with primary care practices. So how do we work with somebody that can be sometimes stubborn to change? I hope I didn't offend anybody there. So how do we do that? Well, there's a really easy way how we can do that in order to create dementia awareness and to get support services and make a more comprehensive care. It's really easy. Give them money. All right, so I don't have a synopsis for Trading Places, but give them money. So some of the things that we're doing, and Dr. Stieg actually alluded to that earlier, is Medicare is providing reimbursement for a cognitive assessment during the annual wellness visit, utilizing a less time constraint assessment with the mini-cog and the ADA. Another thing we're doing, which just came out this year, is the Code GO 505. So after the initial annual wellness assessment is done and the cognitive assessment is done, if there's a need for further cognitive or functional assessment, they will use more lengthy instruments to find out what else is going on, possibly create a diagnosis and develop a care plan for people based on their history obtained from the patient, so experience, and also, And also utilizing the primary care practice rather than the specialists. Because one of the problems we have is that specialists are being overburdened. For every one geriatrician or one neurologist, there are 2,100 patients so that need to be taken care of. So the next step is to get to the primary care practices to kind of alleviate that burden. Now I know that primary care practices are starting, the physicians aren't, there's becoming less and less of them as well. And there are universities who are in cohesion with Medicare to try to get more physicians in with regards to primary care. That was the biggest one yet, thank you. So in this movie, and apologize if you already know what this is, it's actually number 2, and I didn't find an actual slide from Back to the Future 2. So Marty and Doc Brown continue their time traveling, and they go to the future. The whole purpose of it is to make sure that Marty's son doesn't go to prison. However, Marty's greed, basically from a sports almanac for everybody who saw that, leads to the future changing the present. So basically this one is to give a sneak peek of where dementia care planning is headed. So I was actually going to use this in the beginning slide, but I needed something at the end, so. All right, so there's something coming out called CPC Plus. This isn't going to be in all regions, this is in all areas, but it's a test from Medicare to assist in attempting to create a more comprehensive care management for patients and their caregivers within the primary care system. So they initially had the CPC initiative. The CPC initiative was to work as a collaboration between payers and PCPs in the management of patient and caregiver engagement, coordination of care, planned care for chronic conditions and preventative care, care management, and access and continuity of those services. So that was the original CPC. It worked out actually rather well. The payers and the PCPs created a relationship. It actually worked out really well. So they decided to go even further. So the CPC Plus, I'm actually going away from the video. CPC Plus, they have 2 tracks. So the first track is to focus on population health and try to see what kind of collaboration they can have with EMR records so it can make it easier for not only patients, but physicians and healthcare professionals to access a more comprehensive care through medical records. The second track is based upon providing that reimbursement to get more care managers, social workers, in-home consultants, and get them in from the primary care practices and to the patients. So with dementia, for every one patient that you have a $100 reimbursement per patient per month. So you have $1,200 for that patient to be used for specifically to promote and get people in there to help with dementia care management. Another thing, and I'm sorry it's so small, is the New York State Department of Health initiatives. So we have 4 initiatives right now that are going on. One of it is ours, the Center of Excellence for Alzheimer's Disease, which our main component is to create awareness of early detection, diagnosis, care management, and support for primary care providers within the New York State area. There's also the Alzheimer's Disease Community Assistance Program, which is the Alzheimer's Association here. There's also a caregiver support initiative, and there's also a caregiver support initiative for underserved populations, which in this actual county, Chautauqua Opportunities has that grant. This is a new one. Actually, when I was looking up stuff, this is actually kind of nice. Reminiscence therapy. It's going on in San Diego right now. What they're doing is actually building a city that's a dementia village that is utilizing a certain era to bring back memories for those people who have dementia. So right now they're doing a 1950s type city which has a town hall, which has an old style movie theater, diner, to create more of a, to create less stress and more, a better quality of life for dementia patients or people with dementia. So ultimately, what we're trying to do with our care plan is to utilize life experiences from the patient and the caregiver, developing consistency through the medical records and through support services, creating a team effort, a collaboration for everybody, and in increasing and providing better caregiver support. So actually in your handouts that I gave you, there's two things. The first one was the planned, the best practice models. That is actually utilized in Indiana right now under the aging brain model. So what they do is they use these components in their models to see if there's better access to care for those individuals and caregivers with regards to care management. And it's actually going well so far. They initially started with 200 patients, and now they're over 2,000 at this point. So, and they're continuing with that model right now to see where to go next. And then the second one is the plan of care that we utilized at the CAD. So at the CAD, Center of Excellence, we have two sides. We have the outreach side, which Dr. Stieg and myself are in. And then we also have a clinical side. And that clinical side and our side, we both use this plan of care to provide the best comprehensive care management that there is, at least relatively speaking. So we utilize everything that I discussed here and everything you hopefully didn't fall asleep on, and we put it in there, and when we meet with the client and we meet with the patient and the caregiver, we utilize all this information to get to provide them with services, to identify their needs based on their experiences, to identify the caregiver's needs based on their experiences, and then provide them with resources via a letter. That's what we do now, via a letter to the actual patient or the caregiver. And then what we do is within a month and a half, what we do is follow up. And what we're trying to accomplish, if you actually see this one that says patient follow-up note to the physician, what we're trying to accomplish is being more comprehensive in that effect to, after we call the individual or call the caregiver, we try to get back to the primary care physician. Again, this is just in process right now, so it's not something that is standardized at this point. But what we're trying to do is to work with the social worker on site, or work with the physician so they have an understanding at the follow-up visit what the patient and the caregiver did or did not do, and to readjust based on that. Okay, so the example is, and you don't have to clap for this unless you want to. So the point is with dementia care planning is we live in a world where comparatively to 20 years ago when my grandma was diagnosed with Alzheimer's disease, we live in a world that has much more supports. We live in a world that has much more services and is increased awareness, even though sometimes it doesn't seem so. So in order to go further, we can either do one of two things. We can either sink or swim. So, sorry, that was pretty bad. I'm sorry?
Is that Nemo? Who be the second one?
Dory. And I know that because my 19-month-old makes me watch it all the time. Is that because you like Mean Girls, or is it because it's done and you're okay? Are there any questions? Yes.
I just have a comment, and I'm just curious how you guys are finding it out at CN. Like, say I was with my primary doctor explaining I'm spending lots of the support, but I was talking about Medicare, the reimbursement, and he laughed at me and he goes, I can tell you it's not going to happen. And like you said earlier, they're so stuck in the old ways. I see the newer doctors probably doing this, you know, than the older ones.
Dr. Stieg, did you want to?
We spend a large component of our time right now educating the up and coming providers in healthcare schools, School of Medicine, School of Nursing, School of Pharmacy and Social Work. And yeah, they're easy, very easy. What we need your help with, all of you that see patients, work with patients. One of the people here today talked to me about her mother, where she was saying how fortunate I was because my mother's at least in a happy place and her mother isn't. And I said, well, tell me about your mother's troubles and when is she troubled and what medications is she on? And she's on benzodiazepine, which we know is totally inappropriate for elders in general, and definitely elders with cognitive impairment should not be on benzodiazepines. And so she said, well, why doesn't the doctor do that? And this is our biggest challenge. The outreach teams, and we're a team of 3 right now. Our biggest challenge is getting to these traditional primary care providers and updating them on the current management and the requirements of them doing it, for one thing, in the annual wellness visit, and also the most evidence-based current practice, because actually they're not doing it because they're bad providers, they're doing it because they just don't know what else to do, and they're listening to you as concerned family members, and so they work with what they know. They aren't worrying with stuff that they've used in the past for other things. So this is what we need your help with if you're in primary care practices, or even if you're taking parents to traditional docs that aren't aware of this. We will come and help train the providers. That's what we're charged with doing across Western New York counties.
And it's also important to know that we understand that there's constraints with regards to time and financial, and we understand that there's that idea out there that it's not going to work. I mean, obviously, you saw a lot of the other research projects and a lot of other initiatives that came through, and some of them worked to an extent, and some of them didn't work at all. Our goal when we go there is tell us what you need, tell us what we can do to make it easier for you, tell us what we can do so we can accommodate you so this stuff can happen. I think in previous states, previous eras, the initiatives were tell them what they need to do and that's it. We're doing a different approach. Our approach is to utilize primary care practices and tell them what the best practices are, and then find out what we can do to best utilize it with regards to not having those constraints affect that ultimate goal.
Yeah, I just want to say one more thing, and then I promise I'll shut up. New York State, we're very fortunate. I lived in New York State all my life, and many of you have maybe as well, but it's very unusual to hear a New York State taxpayer say, this is the one time living in New York State, it's a good place to be. Because your tax dollars are being used, and the rest of the country is looking at New York State and the monies that the Department of Health have put out there to professional and caregiver support programs, because they recognize the dementia tsunami that's upon us, and it's huge. So it's getting state funding in New York State, and not all states can say that. And what's more important is, other states are watching us, but the federal government that has all kinds of extra money now to put into this and has committed those dollars to it. They're watching what's happening here too. So unlike the traditionalist primary care doc out there that's saying it's never going to happen, it has happened and it will continue to happen. It's not going away because the problem's not going away.
How big of a risk is there of losing funding with all the changes that may be developing?
Losing funding
For the programs he doesn't get either from state or federal.
Our current grant is 5 years, we're into year 2 of it.
Also,
We're already thinking about writing the next one for the next 5 years. It's not going away. What we have to do is we have to demonstrate that we're using the pot of money that they've given us now to make a difference and impact the change.
Mhm.
And that these are our plans for continuing to impact that change, like the Back to the Future.
And
Right.
we're not just utilizing primary care
No.
physicians and primary care practices. We're going to other areas to see what could possibly be next. So we're going to payers. We're going to other grant funders to see what's next and see what would be best practice to utilize with regards to dementia awareness and what would be next with that. And plus, since the Alzheimer's Association isn't going away anytime soon because they're 37 years running. This isn't going away. And even if something happens to us, which I don't think it will, there's something else that will come up that will be the next series of initiatives. So,
On your handout, second bullet talks about causes of cognitive impairment. Down below, second to last, talk about comorbid patients.
right.
My question is, are there precursor conditions that lead into the dementia spectrum?
There are, and there's been a lot of,
Like the one example of a guy at 58, which is a young age, who he has dementia.
right. Okay, so there are evidence-based that say that there are risk factors. So something like obesity, cardiovascular disease, COPD, pulmonary disease. These are some of the things that are smoking. These are some of the things that they have found that are risk factors. Now, these are some of the same things with regards to other diseases that would be the same thing, but we are starting to find out some of what some of the risk factors are. Because Alzheimer's disease, there is no cure, and the official diagnosis doesn't come until after death and when you open up the brain. It is difficult to try to figure out definitively what factors play into it, but we do have a sense of what that is at this point.
And there's a lot of clinical trials that are being done right now. This was just on NBC News yesterday on a segment on the Today Show. Maria Shriver did anybody see it?
Yeah. She's on the internet too.
It was wonderful because she identified a primary care doctor she interviewed that was actually, was it Florida? What state was it in?
It was down south.
Okay, it was somewhere down south in one of the southern states. This primary care doctor was talking about the relevance and the importance of screening cognitive function in all people. We screen for blood pressure, we screen for lipids, we screen for diabetes, and she's saying you should be screening for cognition. And because her point is, the earlier these 58-year-olds get identified and screened for, because by the time they're identified, they've probably had the disease a couple of years. And now that disease has progressed, and oftentimes by the time they're diagnosed, then they're not eligible for the clinical trials anymore. So if you screen them in your primary care practices and you screen them early, you can observe for changes, and as you identify those changes, then you can delve into it more specifically, like you would delve into their hemoglobin A1C for their diabetes. It's the same thing. It's just getting people to recognize it as a requirement for providing holistic.
And there's a lot of research and clinical trials going on right now, because one of the things actually that we're focused on within the Center of Excellence as well is getting Alzheimer's put on the death certificates. So some of the concerns with regards to the death certificates is a person may have dementia, but they go to the hospital, COPD complicates things, and then that's the cause of death.
Right. Yes.
And then the physician doesn't put down Alzheimer's disease, even though that they were technically diagnosed with that prior. So what some of the trials is this Alzheimer's disease, does it exacerbate other comorbidities, or does the comorbidities exacerbate Alzheimer's? And that's what we're going for right now. Yes.
And I'm just curious what you guys have found or if you're even looking at it yet, but it seems like in the past couple of years, more and more people, there's gotta be a correlation where people going for general surgery, knees, hips, whatever, and the families are like, they're totally committed when they come out. you know, like the link between anesthesia and, I just had a gentleman, or whatever, he went in for heart surgery or something. But, they would have had him locked on a lockdown unit for dementia. It took 3.5 weeks for that anesthesia to get out of the system, and now he's totally fine. But if you were to look at him, he looked like he's a behavior problem, blah, blah, blah. So, I'm just saying, I'd be interested in that kind of research too.
There's a lot of research to be done in that area, because I've seen that as well. I remember when we first started doing in-home care consultation back in 2005 with the Alzheimer's Association, my social work colleague at the time and I would go into the patient's home, and we saw this one lady who had, she had had 3 surgeries within the past 12 months, and that was one of the first things that I picked up on, was, wait a minute, one of them was an orthopedic procedure, that was done because of severe osteoporosis. Then, so she had a joint replacement. Then after going through rehab from that, she fell, so then she had fracture on the other side. And then after that, she was given anesthesia for eye surgery. She had 3 general anesthesias within 9 months, and she was in her late 70s at the time. And that, the family was grappling with that. Now, you can ask some neurosurgeons whether or not the 3 general anesthesias in a row would have an impact on, and you'll get one answer, and you can ask others, and you'll get a different answer. I'm convinced that it's just enough to tip you over the edge, especially when you're talking about aging bodies and aging organs, slow down metabolism, slow down excretion. It's gonna take somebody like that 3 weeks to excrete all that.
It's amazing.
Medicine. It is amazing. It's definitely.
It's so crazy.
Anybody else?
Anything else?